It's the PainExam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the PainExam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. Had a little bit of a break. Was on vacation for a bit, and I getting finally back to podcasting and work. And before I get into today's episode, just some announcements. This week I'm doing my regenerative medicine course and ultrasound 2-day event. If you could not make it, you have the option to join us on Zoom. Otherwise, I will be doing this again in September. So mark your calendars, September 28th and 29th, a Saturday and Sunday. We're going to do a 6 CME credit day of regenerative medicine, covering the regulatory issues, the theory, the all the different products, amnio, endosomes, PRP, BMAC, etc., with a demonstration of PRP. Usually I spin it out and inject my knee. And the next day we're going to do ultrasound head to toe. It's a nice course. It covers more or less everything you should need to implement regenerative medicine and ultrasound into your practice. It's something that I truly believe in. I think it's the future of medicine. I think it's ethical, safe care. And there's data to support it, and the data is growing. So this experimental thing is really not as experimental as it used to be. It's probably safer than most of the things we deem standard of care, like cortisone injections. So if you're not a member to the PainExam or NRAP newsletter, just go to nrappain.org and sign up. I'm also going to be phasing out the old PainExam website. Everything will be moved over completely to NRAP soon. So if you're finishing up your PainExam board review, I think almost everybody now is on the new platform, but just I'm giving you guys a heads up. That being said, we're doing ultrasound IV workshops in Manhattan in May and June. I'll probably do more in July and August, but for now, only May and June are set. And the monthly ultrasound courses in New York City. I'll be in Tamarindo, Costa Rica in 2 weeks. If you happen to be there or want to come take a break from surfing and do some ultrasound with me, please just register on the website, nrappain.org. We're also doing the Florida SIP, Florida State PMR meeting on September 22nd. I'm running the ultrasound course. So if you're in Florida or want to come to Florida, please, if you're in Florida and you have ultrasound skills and you're looking forward to teaching with me, please let me know. Shoot me an email. I do need instructors. If you're interested in running a local course and need some support, content, etc., ultrasound machines, I can help you. Please reach out to me. If you're looking to get into a pain fellowship or anesthesia training, I can also help you while you help me. I do need people to work on my platform while I leverage your name and help you achieve your goals of being a pain doc or getting some sort of notoriety or being well known in my platform. So leverage me and help me, and I'll help you out as well. So my email is drosenblum@rmcpain.org, or you could just find my info at the nrappain.org website or painexam.com. I'm all over the place. So that being said, I received an article in my mailbox after my vacation from one of my referring doctors, a physiatrist, Dr. Ruben Ingber in Brooklyn, a great guy who's really well known around these parts. He does a lot of dry needling and trigger points. As you know, dry needling is not something that's typically covered. And that being said, this is an article entitled Iliopsoas Trigger Point Dry Needling and Therapeutic Stretching in the Treatment of a series of 6 consecutive patients presenting with acute lumbar radiculitis and foot drop. So they wanted to do a retrospective chart review and analyze results of these patients with acute lumbar radic with the ipsilateral foot drop. In 5 of the 6 patients, so okay, it's only 6 patients, we're talking about here. It's not 600 or 6,000. These patients had acute lumbar radiculitis and foot drop. I guess you consider it radiculopathy at this point if there's actual weakness, right? It wouldn't just be radiculitis. They responded without need for surgical decompression. In the responders, heel walk returned in 2, 3, 10, 13, and 32 weeks after initiating treatment. Patients received an average of 6.7 trigger point dry needling treatments ranging overall from 3 to 14 treatments, and 9.5 physical therapy sessions ranging from 3 to 16. The average cost of medical care based on the rate of trigger points is $125 and $75 for physical therapy. So it wound up being average of about $1,700 to get these patients better, which, as you know, is a lot cheaper than surgery. Is it cheaper than epidurals? Well, it really all depends on how you do them and where you do them, right? Because now Medicare is limiting us to 3 or 4 epidurals per year, and it depends where you're located. But if you're doing them in your office, it's probably, $200 to $300 per shot. If you're doing a facility, it's $100 per shot. It's really not what it used to be. So, so I think the conclusion based on only 6 patients, but still it's something to take note of, right? Is that iliopsoas myofascial treatments achieved acceptable, risk-free, relatively inexpensive methods of management of care in these patients with severe acute lumbar radiculitis. So when I go into the actual treatment, just to see exactly how these guys did it, they report that myofascial treatment was administered to the iliopsoas muscle, most often using dry needling trigger points, but occasionally ischemic compression, that's deep muscle or myofascial massage, was utilized. It was immediately followed by careful controlled stretching of the iliopsoas muscle. Instruction in home progressive therapeutic stretching program for the iliopsoas muscle was detailed and reviewed as needed treatment. The dry needle at the infrainguinal motor point located 1 finger breadth below the inguinal ligament and 2 finger breadths lateral to the femoral pulse. So this was done blind, not even with ultrasound. The trigger point is dry needling is rapidly peppering the site with fast in, fast out with a 30 gauge, 2.5-inch needle. In larger patients, I would imagine you would need something bigger, but I don't really do blind dry needling of the iliopsoas muscle. Anyway, the PT session was administered, including moist heating pads, inferential muscle stimulation, myofascial massage to the iliopsoas and quadratus lumborum, and instructions in carefully controlled progressive iliopsoas stretching exercise. So I think this is, a small but nice idea / study or report. And what I would be curious to know is how a larger cohort would do, as well as if you did a randomized prospective control trial where you compared the trigger points by itself to the PT by itself versus both modalities combined to see if one of them is superior than the other, or if the effects are only noted when you combine the two. I think it's a safe, as long as you're not stabbing the femoral nerve, right, or getting into any bleeding. It should be safe if done properly, like everything else. And it is cheap, and you're not giving any drugs. So there is something to this. What I did note is, I think I mentioned this in a previous podcast. I had a few bouts of sciatica this year, and I had a superior cluneal nerve block, and the sciatica immediately got better, even though that nerve does not go down the leg. So the nervous system is not as simple as one might think, and blocking a nerve distally or even on a separate branch sometimes helps with pathology, and it's not always attributed to systemic effects of steroid, which I know a lot of people will attribute it to, which of course may play a role in this. Now, since we're talking about trigger point injections, I'm moving on to an email from my billing people regarding trigger point LCD policies. And I'm just going to highlight some of the points here. When you're documenting, include assessment of the patient by the provider as it relates to the complaint for the pain that visit. Relevant medical history, pretty obvious. Results of pertinent test procedures. Sign, date your notes. We know all that. You need to support medical necessity of the procedure. When documenting the trigger point procedure, there must be specific information to indicate the location of the trigger point, the muscles injected, the medication injected, the amount of meds injected, and the post-procedure plan. There's currently no FDA-approved biologics for use as a trigger point agent. So, meaning PRP is not FDA-approved as a biologic for trigger point injectable. The use of biologics and or other non-FDA-approved substances, injection will be denied. So don't start injecting amniotic fluid into people's trigger points or PRP and expect Medicare to pay for it. Same goes for vitamins. 20552, one or two muscles. The 20553 code is used for 3 or more muscles. Now, the diagnoses, I commonly use M79.10, which is myalgia unspecified site. You could also use G44.201, G44.229, which is tension type headache, intractable chronic tension type headache. You could also, there are codes that are not supported, such as vaginismus, which is something I never considered doing a trigger point for. Hemiplegia, central pain syndrome, acute pain due to trauma, chronic pain due to trauma, chronic pain syndrome. So I'm going to have this attached in the show notes, so check it out. Interestingly enough, it's not supported for cervicalgia. I didn't realize that, but I don't use it for that anyway. Or generalized pain of the extremities, like the M79 codes. So don't use it for that. And the caveat: this applies to trigger point injections. Does not with medication with local anesthetic. Doesn't apply to dry needling or acupuncture. Modifier 50 should not be reported with CPT codes 20552 or 20553. The modifier 50 is for bilateral injections. Now, I remember in the olden days, it used to be 6 times per year you can do trigger points on patients. Now, CMS's website is stating no more than 3 trigger point injection sessions in a rolling 12-month will be considered reasonable and necessary regardless of the code built. So whether it's 20552, 20553, that's only going to be billable 3 times per year. I'm assuming people probably overbilled this code. They were probably just doing it, maxing it out 6 times per year. So on this separate document, I'm looking at CMS's website now, not the attachment my billing company sent to me with the LCDs that the previous information is from. It's more or less saying the same thing you need to have for your documentation. Note the doses, the medications. There's not much else here that's actually very different. So that being said, keep in mind, if they need something more than 3 times per year, then you might need to consider doing, instead of a piriformis, for instance, learn ultrasound and do a nerve block, which you will go through the piriformis anyway. So you're going to do a trigger point at the same time, and you're going to do some good for the patient, as well as actually get paid for the procedure legitimately. That's something I consider sometimes for piriformis syndrome. Of course, if you need someone to teach you how to do it under ultrasound, check out nrappapain.org or PainExam.com and come to one of my courses. So I hope this was helpful for you guys. If a patient wants more than 3 trigger points per year, you probably, and talk to your billing people, I would imagine you just need to have them sign an ABN, and they probably would have to pay for it themselves. So just double check with your billing people about that. I don't want to give you any coding advice that can get you into trouble, so make sure you're compliant with whoever handles your billing and coding, etc. Anyway, please reach out to me. Please share the podcast, review the podcast. It's board prep season, so go to nrappain.org for anesthesia, pain, and PM&R board prep. My anesthesia and PM&R board prep, I am looking for volunteers to help me grow the platform. and we could discuss ways that it can serve your purpose and your career goals as well. So hit me up if you're interested. I am always looking for volunteers, and I appreciate you guys for listening to the podcast. Please review it, please share it, and I'll hopefully see you at the conferences. By the way, I am going to be, as I mentioned, teaching ultrasound at Aspen, so if you're there, come say hi. We'll have a PainExam table. Florida SIP I mentioned already. I'm going to have a table most likely at Pain Week. I don't think I'll be faculty this year, but I'll probably be there the year after. I'm still in talks with them trying to arrange that. Pain Week is an interesting conference. It's in Vegas every year in September. It's kind of one of it's a unique conference. It does attract a lot of APPs. And there's just a little different flavor to it. So if you've never been, go check it out. The links will be on the nrappain.org on my conference page, along with Aspen, Florida SIP, Florida State PM&R, and much more. Like NISIP will be coming soon. Some great conferences out there. And these conferences do a lot for us. So if you can go. It's really important. If you need ideas for posters or something, if you're a resident and you want to present something, feel free to shoot me an email. I'll try my best to help you. And thanks for listening. Take care. Have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.